My name is Glen Elliott. I'm a Chief Psychiatrist and Medical Director here, and I will be speaking with you tonight around ADHD and the use of medication. Before I get to that, I have to do a couple of commercials. It's like free TV. There is no such thing. So we do a couple of commercials, and then we'll move on. Wanted to tell you a bit about Children's Health Council. We've been around about 65 years, founded in 1953. It's been primarily focused on youth. More recently, we've actually moved up into at mid to late adolescents and even young adults. And we provide a variety of services. I'm going to describe some of those to you. So essentially, this is our image of the way things we'd like things to be. We'd like kids to feel better, which is, I suspect, every parent's wish, and to ensure that they've got a bright future ahead of them as best we can. I'm not going to read all this to you, but the idea is to try to make find out what's making it difficult for kids to thrive and see if we can relieve those. It can be educational, it may be behavioral, there may be psychiatric problems, there may be behavioral kinds of issues that need to be dealt with in terms of changing their environment, either school or the way they interact with you all as parents. Essentially, our purpose is to try our best to figure out both what's going on and what can be done about it. These are sort of the elements of a kid who is thriving. We're looking for that they're doing well academically, that they have good mental health and feel good about themselves. That's not always easy depending on the age. That they know how to learn and that they can take good advantage of the educational environment they're in, and also that they have good physical development. There are some kids, particularly younger kids, we actually are one of the few institutions that have occupational therapists as well as psychologists and psychiatrists and a variety of other folk. In terms of our areas of specialty, particularly on the outpatient clinic, these are the 4 domains that we focus on and that we have expertise in helping to both diagnose and to treat. There are some of these things there are some areas that we don't do as much on. We don't treat a lot of psychotic individuals, for example, but this accounts for a very large proportion of the population. And obviously, depending on the age, some of these illnesses are sort of more prominent and some of them are less so. We have 4 divisions within Children's Health Council that each of which is interconnected with the others. In terms of clinical services, we actually have two operations that work together, one of which works for Medi-Cal patients here in Santa Clara, the other of which is a self-pay clinic that, for which we do have financial aid for families who might have trouble paying for services. And as I said, we specialize in the areas that I mentioned just before. We just this morning opened up a clinic over in Ravenswood, which is over in East Palo Alto. We have this site, and we actually have a 3rd site down in San Jose, very close to Highway 17. Each of those has slightly different focus. In addition to that, we have what's called community connections. That's really what brings you this talk tonight. And we actually, in addition to this, have classes that we offer to teachers. We recently, last year, became responsible for what's called EdRev. There's a huge expo that occurs in what's now Oracle Park, used to be AT&T Park. We take over the whole operation. The kids get to go out in the field. It's really meant as a family activity. There are lots of, actually you can get free 30-minute consultations there. You can listen to a variety of talks, and it's all free, no charge for admission. Look it up on our website. You'll be seeing it. At this time, it's happening on this date I can remember. It's May 4th, which happens to be my birthday. So they're celebrating my birthday by having this lovely activity. It's been going on quite a while. This is the second year we've been responsible for it, and it really brings in some very nice speakers, and families really enjoy the day. The kids love being able to go out and run the bases on the baseball field and all that good stuff. We also have two schools, the oldest of which is Esther B. Clark School, which is a so-called non-public school. That means that it's nearly all of the students are from public schools where they behaviorally were unable to get a good education, and they were referred to this school. They typically stay with us about a year to year and a half, and then go back. The intent is to get them back into their previous school where they'll finish their education. About 5 years ago, maybe 6 now, we created a separate school called Sandhill School, which is a private school. Its major focus is on learning disabilities. And in fact, kids have to have some sort of a learning disability to be eligible to be in the school. What distinguishes this school from some others is that we have a very close association with the clinic that we have, so that if kids have behavioral or psychiatric issues that are also interfering with their education, we've got people on site that can actually go to the schools down here and the clinics upstairs. So it's very easy access, and we provide the services that are needed, both in terms of evaluation and potentially intervention, which can range from language interventions to OT to psychiatry to psychology, to any of those that might be needed. So that's us. One of the more recent innovations we had was the so-called Initiative for Adolescent Anxiety and Depression. That's been going on for about 3 years now, and we've substantially increased the number of personnel who are expert in dealing with mid to late adolescents and young adults who are suffering from anxiety and depression. As part of that, we have what's called an IOP, or an intensive outpatient program, that kids can attend for, it's a 12-week program after school that's an integrated program with parents and children, with the intent of making sure these are kids that have been suicidal or engage in self-harm or other behaviors that are potentially dangerous to them and other people. That's actually a program that we've got now an affiliation with Stanford. So we've got personnel from both Stanford and Children's Health Council. EdRev, that's what I was looking for, the EdRev Expo. So that's coming up, and as I said, it's free. It is good to register. Although I think you can register on site, but I recommend registering in advance, so that way we know who's coming. It's on May 4th, 2019. You can, an outdated slide, I think the name has already changed, but to Oracle Park. It is quite the day, and I would strongly recommend it to anybody who is interested in sort of learning more about this area. There's a program, you can see what talks are coming and all of that. Enough commercial. So here's what we're going to be talking about tonight. I want to give you some broad overviews. I've been working with kids with ADHD since 1984. It is not my exclusive interest, but it has certainly been a very strong interest. I've been involved both in research and in clinical care and in diagnosis. We have a ADHD clinic here, which they were kind enough to name after me, which I could have survived without. But anyway, we've got the Elliott ADHD clinic, where we do evaluations. We also have available a variety of people who can help with interventions, whether it's medication or behavioral interventions, or working with families to help create a better structure, or schools to help with that as well. My major interest is in medications, and that's what we're going to be talking about tonight. I don't want to in any way imply that that's the only thing that one can do with ADHD. There are lots of other things. It's just that you guys are going to want to go home tonight, and we're going to have trouble getting through the material that I've got. So there are other talks during the year, and I should have reviewed it and didn't, about behavioral interventions for ADHD. We've got a talk about diagnosing ADHD. So there are several talks during the year that deal with different aspects of this. but today we're going to be talking about medication options. So broad observations. One of the things that our field came to relatively slowly, it's in my professional lifetime, began in the late 70s and really the evidence for it accumulated mostly during the 1990s, 80s rather, is that for many individuals ADHD is a chronic, potentially lifelong disorder. Even as late or recently as 1975, I remember as a medical student, one of my wife's, I've only got one wife, my wife has a cousin who had a child who was diagnosed at age 9 as having ADHD, and the physician said, if you can just hold on to puberty, life will be wonderful, it'll all magically go away. What research has showed us is that some people that's true, and we'll talk about them, but for many people, at least 60%, the problems that ADHD creates go well through adolescence, probably certainly into young adulthood, and probably become lifelong kind of difficulties. The exact numbers vary depending on sort of how much symptoms you want to use to describe the problem, but only about a third of individuals really completely either get over having ADHD or more likely develop techniques so that it doesn't become impairing for them anymore. Out of curiosity, has anybody been to the talk that my son and I have done? Oh, you've missed a lot of fun. I think I'm not sure whether it's on the resource site or not. My son, who's now 35 and actually just graduated in June as a child psychiatrist, but certainly as a child had quite significant inattentive ADHD. And some of the examples I'll give will be from my personal life and the joys that we had together as he was growing up. He's an interesting example of somebody who actually continues to have significant symptoms and yet is very, very successful. He's found a way to adapt. He does use medicines now. He didn't when he was younger. He has a recently acquired wife who is part of his support system that keeps him on, if not the straight and narrow, at least a little less windy path. So there is some good news about ADHD. Again, these are data that have come out of, this is by far the best researched area in child mental health. More kids have been involved in studies. We followed them longer. We've literally followed thousands of kids for at least 15 to 20 years, and some longer than that. And one of the things that we've observed is that on average, over time, everybody gets better. Symptoms become less severe. That's part of why we were under the misimpression earlier that ADHD went away with puberty, because one of the things that definitely diminishes with time is physical hyperactivity. So kids who are bouncing up and down and really can't sit still, usually by the time they get into their early teens, that diminishes into fidgetiness and restlessness, but not nearly as disruptive as the earlier behavior. And that's what, in fact, it used to be when I first started in the field. This was called hyperactivity because was the prominent feature. It turns out that that's only a piece of the overall picture, but it does get better, as does other aspects. We'll talk about the downside in a minute, but on average, people get better with time. Also, we have found that a very wide array of interventions can reduce symptoms, at least in the short run. That includes medications, it includes behavioral interventions, it includes special education programs that have well-structured school settings. It may include, although this is still a little more controversial, there are now some what are called biofeedback approaches that are attempting to help train the brain to be more attentive, less impulsive, less hyperactive. All of these have been shown to work very effectively in the short run. The difficulty is that essentially none of them, and that certainly includes medications, have been shown to necessarily change the long-term course of the illness. So it's a little like having a cold. You can decide to medicate it and the cold will only last 2 weeks, or you can decide not to medicate it and it'll go away in 14 days. The symptoms are suppressed, which is not trivial because that may allow kids to function in other areas that they wouldn't otherwise be able to develop. And you can just think about what we expect kids to be learning between, say, 6 and 14 or 15. Having better attention, less likelihood of interrupting, those kinds of things can be highly valuable, even if they're only temporary. But it doesn't seem to change the brain itself. That's something that is both being looked at very vigorously and also some ways feared. The nice thing about what we currently have is we're pretty sure it doesn't do bad things to the brain either, and it also doesn't seem to do good things to the brain. It just seems to reduce the symptoms while you're taking it, and then it wears off. That's also true with most of the other interventions, including the behavioral interventions and certainly the classroom interventions. Any small change and the symptoms come back very quickly.
So do we know what these drugs do on a developing brain?
What I just said is, as far as we know, it doesn't have any effect on the developing brain per se. I mean, there have been no, and these have been around. Ritalin was the first published study of ADHD on what was then hyperactivity, and Ritalin was 1961, and they've been studied a great deal. There have been a couple of studies that have suggested there may be some increased cortical development in areas where we'd like to see that. Whether that's physiologically relevant or not is really quite unclear. There have been no studies to suggest that it slows down brain development or prevents the brain from continuing to develop the way it's supposed to.
That's true for the stimulant and for the other classes?
As far as we know, yeah. I mean, most of the other classes are more recent, although essentially all of them have been around at least 20 years at this point. But part of the difficulty there is that we don't have huge tools for looking at brain function in detail. And nobody's ever going to agree to do a study where we leave half the kids untreated and half the kids treated for their, from 0 to 20. That ain't going to happen. So what we end up looking for are signals that suggest that this is doing something good or bad in the long run, and no such signals so far have been shown with any of the medicines that we've got. But it's a great question. Yeah.
So there has been follow-up on the children.
Oh yes. Yeah, absolutely. Yeah, and I was involved in a study which you're welcome to look up. It's by far the biggest and longest lasting study. It's called the Multimodal Treatment of ADHD, or MTA, sponsored by the National Institute of Mental Health. It involves 6 different sites, lots of kids, and they were randomly assigned to no treatment, to community treatment, which was pretty close to no treatment, to medications only, to behavioral only, and to a combination of behavioral and medications. And medications were shown to be the most beneficial, and at least in the short run, but we treated them for about 14 months and then sort of sent them back out into the community. By 3 years, we couldn't tell the groups apart. Essentially, all of the interventions, the kids looked very similar to one another. Yeah, they've been followed. I think the latest available data is late teens to early 20s. They're still being followed. Interestingly enough, the National Institute of Mental Health, which initially sponsored it, for a variety of reasons, decided they weren't interested any longer, so it went over to National Institute of Drug Abuse because there's a lot of interest in what medicines do to the brain, or these kinds of medicines do to the brain. So many of the follow-up studies were looking more at risk-taking behavior and those kind of things. But yeah, the kids are still in the study. I'm not involved with it anymore, but they've got to be mid to late 20s at this point. It takes about 5 to 6 years lag time between when they reach a data point and when the data begin to get analyzed and come out. One more question.
Is exercise being considered as part of today's agenda, the overall?
In this title, no. Am I opposed to exercise? Absolutely not. If you've got a kid who likes to exercise, there is reasonable evidence that it is certainly not harmful and it may well be helpful. There's even a guy right now who's head of a major a mountain bike manufacturing firm who is convinced that ADHD cured, that bicycle riding cured him and his child of ADHD, and is trying to get some studies going to try to prove that. But there are very few systematic studies of exactly what exercise does, and it really depends on the child, because there are a lot of children where getting them to exercise is would be a whole nother session. My two would be included in that group. But no, we're going to be talking about medications here. We're not going to be talking about alternative kinds of treatments, and exercise is certainly, one of those. But there's absolutely zero evidence that exercise is bad for you unless it entails parents yelling at you the whole time to get them to do it. And that's, in general, anything that requires you yelling at your child probably is not an optimal activity. If you can seduce them into doing it in some other way so that they think it's their own idea, sometimes saying, no, don't exercise might even work, but probably won't. My son would have said, okay, well, I won't. All right. The other thing that as we've recognized that ADHD is still present, particularly in adults, is it really has helped us to understand that ADHD is not per se a bad thing. That in certain settings, under the right circumstances, it actually can offer real strengths. So in this area, for example, a lot of startup companies have adults with ADHD because they can handle multiple tasks. They actually love in a chaotic environment in which they're juggling 12 balls simultaneously, and it doesn't really matter much if 5 of those balls turn out to be useless or fall down if the other ones manage to catch. There's actually a lovely study, which I don't have time to go into in great detail, that there's a gene that is pretty closely associated with ADHD. It's not the cause of ADHD, but there's at least a group of individuals who have this gene and have ADHD, and they decided to do a worldwide map of the gene distribution. And for those who don't pay attention to such things, the belief is that humanity started in North Africa and then migrated sort of both directions, but from our point of view, up through Europe and into what's now Russia, and then over what was then a land connection between Russia and Alaska, and then down North America, and eventually wended their way down into the tip of South America. Interestingly enough, this gene exactly the lowest density is North Africa rather, and the very highest density turns out to be the tip of South America. And the argument is that these are the people who said, oh, look, there's a hill over there. I wonder what's on the other side. From an individual point of view, that's not necessarily the best survival technique, but from a humanity point of view, it actually obviously can have some real advantages. They're the ones that try oh, that looks like an interesting plant. I wonder what it tastes like, etc. So one of the arguments in a hand-waving way is why is ADHD still around, is that it really has, from a population survival point of view, a lot of benefit for the population, not necessarily for the individual. But similarly, my son's a little bit of an exception. He's actually interested in child psychiatry, but people who go into medicine, for example, often if they have ADHD, they'll go into something like emergency medicine where there's a lot of chaos, a lot of this rapid decision making, not much of a chance to get bored because there's always a new case coming up, as opposed to something that requires meticulous attention to detail like neurosurgery or something like that. Okay, bad news. There is no so far treatment that has been identified that changes the long-term course of ADHD. I already mentioned the long-term course naturally is that things get better, but we haven't found a treatment that reliably speeds up that process or slows it down or anything else. At this point, it sort of follows its own muse. The other thing which we have good evidence for is that inadequately treated ADHD, and I'm not talking just about medications, but if you don't find a way to help a child with his problems with ADHD, it's going to make other developmental goals like making friends, doing well academically, those kinds of things are going to be more difficult. as we'll talk in a minute, well, actually the next point is ADHD rarely comes just by itself. Only about a third of kids have just ADHD. The other 2/3 have some other kind of problem, which can be a learning disability, can be anxiety, depression, something called oppositional defiant disorder, a variety of things. And some of them are blessed with 3 or 4 or 5 diagnoses. And essentially, this shouldn't surprise you, the more diagnoses you've got, the heavier the load is. So many of those have no medication treatments, so one of the arguments for treating ADHD with medicines or with whatever is that at least that's one less load that the kid's carrying, and it makes if you imagine you've got a speech and language problem, the exercises on that are boring as all get out, and being able to deal with boredom better allows you to sort of go through those other kinds of programs. I, for a while, worked with the Center on Deafness at UCSF, and really hadn't even thought about it before I was working with them, but it turns out that ADHD and deafness are a truly horrible combination, because deaf children only learn when they're looking at the person who's teaching them, and ADHD does not encourage that. So they're effectively treating their ADHD, so they're able to sit and actually pay attention to the person who's trying to teach them. It makes all the difference in the world in terms of the likelihood that they're going to succeed. The other thing I want to emphasize, and this is not just about medications, is that all treatments have side effects. If somebody says, I have a treatment that works 100% of the time and has 0 side effects, it's really time to put your hand on your purse or billfold and back away slowly, because there is no such thing as 100% efficacy for any of these treatments, and there are no such things as treatments that have no side effects. There are things that have more side effects and less side effects, but there is inevitably something that's going to be some sort of a side effect, regardless of what treatment you're dealing with. With behavioral kinds of things, it may be that you only learn, for example, you only feel like you need to learn while you're in that particular environment, and it actually doesn't. You think you're free when the substitute shows up and doesn't know what he or she's doing. The side effects are not necessarily going to be identical, but we'll certainly talk about those with medication. And one of the difficulties is that side effects take time to learn to really suss them out. Medications we've had for decades. We really know what they are likely to be. Some of the other treatments, we just know less about them. I often joke, if you want to take a medicine that's going to be the most effective it's ever going to be, with the fewest side effects, take it the day it's released, comes out on the market, because it's all downhill from there. It's not going to end up working as well as we thought it did, and there are going to be more side effects than they thought they were going to have. So, already mentioned ADHD is a chronic disorder. Impairment can take a lot of different forms, and they're going to be age dependent. So what gets you in difficulty as a 3-year-old is going to be very different than a 6-year-old. It's going to be even different than a 10-year-old, et cetera. And what that means is that as a parent, you have to be agile enough to notice when ADHD is beginning to get in the way, and try to take whatever steps are necessary to reduce the problems that it's causing. With my son, I began to recognize that he had something going on when he was about 7, because his second grade, we're less than a block away from school. He came running home very excited with an envelope that was supposed to contain his first grade card, but in fact was empty. Somewhere between home and school, it magically disappeared. And that was sort of a warning sign that he had other things, but that was certainly one that stood out as, okay, so organization and losing things is going to be a problem. Continues to be, actually, at age 3. Issues, as I noted, change with time. We'll talk about adolescence, because there often it's not really the ADHD that's a problem. It's something that we call executive functioning, and we'll talk about some of that briefly. As I've said, both medication and non-medication strategies can be effective, and both may be needed. So if you've got a kid like mine who loses things, medicines aren't necessarily needed for that. What's needed is a surefire way of getting things from home to school and from school back. And that's actually a fairly easy behavioral kind of intervention that you can put into effect with a little bit of positive rewards to make sure that they do it. I wouldn't say we were horribly effective at this as parents. When he graduated from high school, much to my amazement, we opened up his backpack, and I swear there were permission slips from his sophomore year that had never gotten, we'd never seen the light of day. But it is possible to do relatively simple things. One thing that's really important, and we should be able to talk about a little bit about later, is having a good, strong connection between home and school is really crucial, both because you need to know that things are going okay and not wait necessarily until they call you in for your first parent conference. You're going to be more helpful to the child if you're getting information. This is easier now than it used to be because a lot of schools post homework on websites and you can sort of get access to it. But it really still is very important.
Excuse me.
Yeah.
Are you going to dig deeper into issues change with time?
Yeah. So this is a broad overview of places where one potentially can intervene. All of these can be important. As I said, we're only going to be talking about medications, but from an environmental point of view, there are certain, I'm sure many of you have experienced this. If you've got children who are in elementary or high school, there are some teachers who are more attuned to kids and sort of able to bring them along. There are other teachers that really don't have a clue what they're doing, and the child feels like a failure because he or she never got around to even figuring out what the assignments were, let alone getting them done. By programmatic, it's sort of these kids really thrive on well, they don't enjoy it, but they do better when they know what's expected of them. Morning routines can be really, really difficult, and giving them an opportunity to even though you've told them 1,000 times, actually writing it down, having them check off that they've done whatever they need to do in the morning can be really useful. Psychological really has two different versions. There's the so-called intrapsychic, which is more dynamic therapy. Not a lot of proof that that helps with ADHD, but many ADHD kids, by the time they're 8, 9, or 10, can develop depression and anxiety as a result of feeling like everybody hates their guts because they're constantly being yelled at. And therapy sometimes can be helpful for that. Cognitive behavioral therapy, particularly with younger kids, is typically focused on parents and teachers creating a structure that has clear rules, clear expectations, and rewards that go with the kid being able to follow through on that. Medications we're going to be talking about, and then nutritional changes has to do with vitamins and supplements and those kinds of things. And again, that's a whole different talk, and we won't have time to really spend any real time on that. This, I apologize, it's maybe a little clearer in your handout, is a schematic of what we know about at this point regarding the circuits in the brain that are related to ADHD, and also to something that I touched on briefly called executive functioning. And it turns out those are quite distinct systems, and the feedback goes back and forth. The prefrontal cortex is where we do most of our planning, and we believe that's where most of the difficulties arise in terms of kids making impulsive decisions and not being able to stay tuned in to what they're supposed to be tuned into. We think the reason for that, and certainly where the stimulants do most of their work, is in a very primitive old part of the brain, a deep brain structure, and called the substantia nigra. And dopamine is thought to be the main reward system, and there's lots of evidence that surges of dopamine can reinforce all sorts of behaviors. So the idea is that stimulants are increasing the activity of that and helping to sort of boost better decision making. It turns out that hyperactivity is actually a separate mechanism from attention and distractibility. The cerebellum is somehow involved, and we don't really know the details of that. In general, the cerebellum sort of smooths things out, so as you master a technique, it helps you do so more with less effort, and whether it's playing baseball or learning to run or whatever, the cerebellum helps sort of smooth off the rough edges and make things more efficient. How that fits into ADHD is actually still something that we're still working on. And then executive functioning, which is the blue, turns out to be a very different system, and so far we don't have medicines that actually affect that. And executive functioning turns out to be usually the areas where high school students have by far the most difficulties, and at this point most of the interventions for that are behavioral. And again, they may already have happened already, but there are talks that we give every year around executive functioning because it has turned out to be a very important area, particularly for adolescents. Executive functioning has to do with being able to do things in an efficient way. The example I usually give, because I can't do it, is creating a gourmet meal where you've got 7 courses and you need to have the things that are supposed to be cold ready on time and cold, and the things that are hot ready and on time when they're supposed to be hot, and making those kinds of decisions about when do I start something, what order do I start it in, when do I actually have to start worrying about it, all of those kinds of things, what do I need in preparation of that, can be significantly more difficult if your executive functioning doesn't work so well. Translated into what happens in school, how many have 4th graders or had 4th graders? What happens in 4th grade? What project?
Writing.
Mission, yes, I've done so many mission projects I cannot begin to tell you. But I only have 2 kids, but we had friends. So the mission project is really about the first time when kids have a multi-step kind of activity. And there are a lot of kids without ADHD who find it somewhat difficult. Kids with ADHD, it really becomes almost impossible, and it really requires an enormous amount of external structuring. And that's, again, there are a lot of kids without ADHD where their brains haven't matured quite enough yet to make that possible. 5th grade, they usually have something else. I think it's often studying another state and doing a report on a different state. But again, it's a project that has multiple steps that you need to do in the right order. You need to estimate how much time each of them is going to take, all of those kinds of things. That's executive functioning. And often with kids where that's a problem, that's when it begins to get really picked up. Because in 5th grade particularly, the teachers, particularly teachers who don't know what they're doing, will say, your kid needs to really stand on his or her own 2 feet, and you need to back off as a parent and just let him fail because that's the way they learn. That is not the way kids with ADHD learn. They learn to fail. Processing speed is also involved, but it's really it's this more complex sort of weighing priorities and finding an efficient way to get from point A to point F. Medicines don't improve short-term memory or processing speed. Neither of those.
So you say that it's the project-driven curriculum, so the project is especially difficult for people, for the children with
Right.
ADHD. Do you think that American curriculum, school curriculum, that is, emphasis on the project-driven, so it's like, because my kids went to the European school, and here it's completely different.
Yeah.
European school, they have a small homework every day.
Sure. Yeah, I mean, our system, I have a colleague who loves to say, if you really want to create an environment in which ADHD kids perform as badly as they possibly can perform, you'd be hard-pressed to come up with a better model than our school system. They're expected to sit still for long periods of time, listen to often very boring things about which they have very little interest, not be distracted by having 35 or 40 other kids around them, et cetera. I mean, it is not a great environment. There are schools that are designed for kids with ADHD, which have, in terms of effectiveness of getting them focused and doing their tasks, are as good as medications, if not better. So yes, there are issues with our school system that certainly contribute to the problem. But I mean, if the kid didn't have the problem, they wouldn't be contributing to. I mean, the reason it works is for a lot of kids, by that age, they've developed the ability to process that information and they do okay. One more question and then, yes?
In the picture, so medication in the picture,
Yeah.
where is it acting?
It acts in a couple of different places, but the stimulants, which are the ones that have been around the longest, act here. They increase the likelihood that you're going to get a positive burst saying this is a good thing, you should pay attention to it in situations that require your attention. They also, a mechanism not quite as well understood, they decrease overall activity levels, and that's true whether you have ADHD or not. Kids respond very differently to stimulants than adults. Their activity level decreases, their impulsivity decreases, and their attention increases. The attentional issue is true for adults as well. I mean, I'm not sure, I'm not going to ask any who in the room has taken a stimulant, but one of the reasons that college-age students take stimulants is that it does actually increase their ability to focus for a while. Unfortunately, it also allows them to overestimate how well they're going to do on a test, so they may kind of wash out. It has other kinds of problems. But the big difference between kids and adults with stimulants is that kids, regardless of whether they have ADHD, don't get stimulated with them. They don't get a rush from stimulants, whereas adults do. And that's really what adults tend to end up abusing stimulants with, is because they get this rush, they develop a tolerance to that, they keep raising the dose, and then they get into bad trouble.
Why are there places like Newport Academy for kids who have taken these medications and may have been addicted, and there's all these like addiction therapies out there for these kids?
Well, there aren't that many out there for these kids. Some of it is misdiagnosis. Usually you're talking about mid to late adolescence. Obviously, at some point during adolescence, their response to medicines can change from what we see in younger kids to what we see in adults. And we don't know exactly when that occurs. And the numbers, I mean, there's no question that stimulants are being abused. They're much more available now. There are lots of kids who don't have ADHD who end up taking them. You're usually talking late high school and college age. And they do get a rush and they do end up potentially abusing the medications. But it's a relatively small number. I'm not saying it's trivial, but kids with ADHD do not have that response. And we're also talking about, for these kind of treatments, they don't develop tolerance to the ADHD benefits, and if they have ADHD, they continue to benefit as adolescents and adults with a very similar response to what we see in kids. In some ways, the adult ADHD individual is the oddball out. He or she is going to respond to stimulants very differently than an adult without ADHD. But the abuse of stimulants is one of the things that has become an unintended consequence of recognizing that kids and adolescents, and adults can have ADHD and can respond well to stimulants, because they may abuse it, although that's relatively rare. Much more commonly is somebody will say, I'll be your friend all day if you'll let me have your stimulant, and they are more than willing to trade off stimulant for a friendship, even if it's only for a day. And the abuse largely occurs because the drugs are readily available at that point. And particularly if you're in college, you're going to be monitoring your own medications, which can be a problem. Okay, so I want to do just a quick model for the way I think a good collaborative relationship between the prescribing doctor, and stimulants have to be prescribed by doctors. The most common prescribers are pediatricians, because they're the most numerous, behavioral and developmental pediatricians, and child and adolescent psychiatrists. And depending on the complexity of the case, pediatricians may feel fine with that. Most pediatricians are comfortable with prescribing stimulants. Many pediatricians get less comfortable with prescribing some of the non-stimulants that we'll be talking about. And certainly if the FDA endorsed stimulants and non-stimulants don't work, then they tend to make referrals to child psychiatrists or to behavioral and developmental pediatricians, both of whom have significantly more training in treating ADHD. Whoever you find, you need to meet regularly with them, particularly early on, to make sure that things are working well, that the dose is right, that if there are side effects, they're being dealt with. You need to, as a parent, if you've not been on your child's not been on medications, it's important to talk about likely side effects and even unlikely side effects. Also, what kind of targets we're really looking for, and often that requires some sort of a level of collaboration with the teacher, because a lot of the complaints are going to be coming from the school, not just the home. How we determine the best dose and how we're going to monitor how the kid is doing in terms of things like weight and height and those kind of things, and we'll talk about some of those side effects. Yeah.
Are there any studies that show, as you talk about stimulants and non-stimulants, as you age, like you're getting past adolescence, does one of the two work better?
So the question was, are there any studies that show that as you age, stimulants versus non-stimulants work better? Unfortunately, the answer is that there haven't been those kind of studies done. We know that stimulants continue to work, but we also know they get to be more problematic as kids get older. There's a huge difference between coasts. So in California, it's very, very difficult for an adult to get somebody to prescribe him or her a stimulant on a regular basis. There's just more hoops to jump over than many doctors are willing to jump over. On the East Coast, particularly major cities like Boston and New York and Washington, D.C., there's much more willingness to prescribe stimulants. So one of the big surprises that people from the East Coast sometimes get was when they come here is they assume that they can find a doctor easily and continue their medication, and they suddenly discover there's nobody who's willing to take them on as a patient. But the non-stimulants, and we'll talk about some of the downsides with those. The non-stimulants do continue to work in adulthood. In fact, many of them were studied initially in adolescents and adults. We'll talk later about sort of why people may prefer one over the other. But in general, all of the stimulants that work with kids seem to work with adolescents and adults. Yes, ma'am.
Do you ever use genetic testing in terms of looking at the profile of the person and how they are likely to respond to certain classes of drugs?
Yeah, it's a great question. It's become very popular, and the evidence, particularly in kids, that it actually predicts. What it's doing is looking at variations in liver enzymes and looking at metabolism, which is only one part of. There's nothing that looks at the actual, because we don't know exactly how to do that. There's nothing that actually looks at whether this drug is actually going to be beneficial for this particular child. What it supposedly does is to predict whether or not a kid is more likely to have a bad reaction to medication. All of those studies were done in adults. It's actually controversial in adults. There really are no comparable studies done in children. We actually do offer it here if parents really want it. It has, in my experience, very little predictive value. Like for example, one of the things that I have yet to see a child who's had one of these tests who didn't, for whom all of the serotonin reuptake inhibitors were thought to be potentially risky and shouldn't be used, even though kids tolerate them very well. And it's just something about the way kids' metabolism gets looked at. So I don't use them very regularly. There's certainly nothing that's going to predict whether a stimulant versus a non-stimulant is going to be more effective. And frankly, with stimulants, and among stimulants, there's even less evidence to suggest who's going to respond and who's not. But with stimulants, since we get a very quick response, it's probably way less expensive and faster to just try a medicine and see whether or not it has a good effect, which is likely 65% of the time. So in general, the answer is no. There are some kids who seem to be very sensitive to medication where I might use it to see whether or not they're so-called fast metabolizers or slow metabolizers, to see whether or not that's going on. But in terms of predicting really specific response to a particular medication, the science just isn't there yet.
If I just ask a follow-up on that?
Yeah.
Oh, so when you're you have a child who you want to treat, but they don't have any experience with medicine.
Right.
You just kind of pick one and start.
That's where we're headed.
Okay.
When we get to this slide, that's where we're headed. Yes.
Learned that
take of dopamine, and it was related to drugs like Ritalin and
Atomoxetine, yeah.
and it can affect those.
I'm not arguing that it doesn't have an effect. I'm just saying what it doesn't do is predict whether you're going to have a response or not. I mean, it may affect your dose, but you're going to start at a low dose and build up anyway. So, it doesn't provide much incremental information. And part of it, I'm not even saying that it won't ultimately prove to be useful, but the companies have not studied kids. They've studied adults, and kids are not just little adults. Their livers are very, very different, particularly prepubertal kids have very different liver action than what you see in post-puberty. So I don't have a lot of faith. If you give me a 16 or 17-year-old, I might be interested. If I have a 7 or 8-year-old, there's just zero evidence that the tests really have been tested on that age group to show that they actually help predict. Now, there are other people who use them on kids all the time, and they believe they get benefit, but there haven't been any controlled studies to really show that it actually speeds. I mean, what you're interested in is how quickly can we find a medicine that actually works. And at the moment, clinical judgment is probably the best. So part of the reason, particularly with stimulants, that doctors don't care about a whole lot of testing is that we've got excellent research that shows that 65% of the time, if you have a well-diagnosed child with a child with well-diagnosed ADHD, the first stimulant you pick, whatever that stimulant is, there's only 2 classes at this point. There's methylphenidate and amphetamine. 65% of the time, the child will show significant behavioral benefit with tolerable side effects, which I have to tell you is way better than any other medicine that we've got in child psychiatry. And that if the first one doesn't work, so let's say you started methylphenidate and that turns out to either have side effects or just doesn't show any benefit, if you flip them over to the other medicine, so in this case amphetamine, 15 to 20% of kids will respond well to that medicine and have fewer side effects, or both. Yeah?
Just to be clear, those percentages are strictly based on children who only have ADHD and not ADHD in conjunction with it.
No, actually, you can have, I mean, you need to have well-diagnosed ADHD. You can have other kinds of problems. It may not fix those problems, and there are a couple of things where this may be a little less accurate. So if a kid has anxiety, for example, one of the things we know is that some kids with anxiety may respond to stimulants by becoming more anxious. So their ADHD may get better, but their overall behavior may get worse because they can't leave the house because they're terrified. There's some fascinating, very poorly explained types of anxiety that are unique to stimulants. So for example, there's an insect phobia that occurs in some kids with introduction of stimulants where they suddenly become terrified of, usually not insects broadly, but some specific insect, a mosquito, a fly, something, spiders, and it's strictly drug related. When you take them off the drug, that phobia goes away and they stop panicking about a fly buzzing around them. Yes, there are some kids where we do have to worry about that, but things with like a learning disability, executive functioning problems, those kinds of things, these data still hold.
You have mentioned many times learning disability, but my understanding was that ADHD is not considered as a learning disability.
It isn't, but about a quarter of kids with ADHD have a learning disability on top of it, and similarly, about a quarter of kids with a learning disability have ADHD. So they're unrelated, but they often co-occur. And I use that partly because we have a school for learning disabilities, so we get to see it, but the kind of effort required for somebody with a learning disability to overcome that is a lot harder if they have untreated ADHD, because it's dull, boring, repetitious kind of activities that, yeah, and learning disabilities don't have medicines that fix that, so you end up having it's an educational kind of treatment. Yeah, but I could use Actually, oppositional defiant disorder is quite interesting because we don't have a specific treatment for it either. And I don't know how many of you have a child with oppositional defiant disorder. It's defined as and often occurs quite young, as early as 2 or 3. But these are kids who essentially anything you want them to do, their first response is going to be no, regardless of what it is. Not just, I don't want to do my homework, but essentially anything you'd like them to do. It's a very dyadic relationship. You want them to do something, they're not going to do it. They're going to resist doing it. There's no specific treatment for that, but interestingly enough, good response to the ADHD, which almost always co-occurs with oppositional defiant disorder, also reduces the oppositional behavior because the kids are less impulsive, they're a little better able to negotiate and to sort of think about the consequences and that kind of stuff. So there's no specific treatment for that, but effective treatment of ADHD can reduce oppositional behavior. There's also a type of anxiety that stimulants seem to help with. So if you have a kid who is really, really hyperactive and constantly getting into trouble, many of them become quite anxious. There's a subgroup of them who don't. They always fascinate me. They don't have any friends. They've never had a teacher who ever liked them. Their parents can barely tolerate them, and yet they are blissfully unaware of all of that, and they are convinced that tomorrow is going to be a brighter day, and then they're going to have their first ever friend, and everything will be wonderful. Most kids with ADHD, by the time they reach 8 or 9, develop some level of anxiety because of the way people react to them. And those kinds of kids do end up having lowered anxiety when you treat their ADHD because suddenly they're not being yelled at, they're actually succeeding where before they were failing, and they develop more confidence. There's sort of two populations. Anxiety is a very common childhood disorder, and you can end up with both. Those kids, usually stimulants alone can be problematic. Or you can have these kids where the anxiety is clearly related to the sort of way they expect the world to treat them because of their ADHD, and many of those kids become less anxious as they effectively respond to the treatment. That makes sense? Yeah.
Can you explain what's well-diagnosed ADHD? What does that mean?
I mean, there are different levels, but it's more than just a pediatrician looking at a kid for 5 minutes and saying, yeah, I've got ADHD because the teacher doesn't like the way he's behaving in class. What we're looking for is a consistent pattern across several different domains, usually school and home, sometimes office, where kids have problems with impulsivity, long-standing problems that started when they were young with impulsivity, hyperactivity, and attention kind of problems. We don't have, well, we've got a couple of computer-based tests that help measure some of those things, but most of it is still clinically determined. They're based on questionnaires. We are partly, at our clinic, we're also looking for likely comorbid conditions because we know these kids can have some difficulties. But in terms of diagnosing the ADHD, it's that level where we want a long-term pattern. So if somebody comes to me at 13 who has a completely clear history, they've never shown any evidence of ADHD at all up to that point, and they're now very hyperactive, very impulsive, they're doing all sorts of things that are not socially appropriate, they can't pay attention for more than 5 seconds, the first diagnosis that comes to mind is not ADHD, because we think ADHD is really a lifelong problem. And that where it gets diagnosed depends on what the kid's capable of doing crosses over what society expects. So for 3-year-olds, kids who are very hyperactive and impulsive may get identified because they keep getting kicked out of preschool, because they're biting and they're kicking and they're not playing and they're not doing circle time and all of those things. The typical diagnosis, so that actually is so-called impulsive hyperactive ADHD. The typical diagnosis for so-called combined type ADHD, which is those 3 domains I mentioned before, is usually around 6, 7, or 8, usually 6 or 7. Not because they're worse, but because all of the non-ADHD kids know they're not supposed to get up out of their seat, know they're supposed to raise their hand and wait to be called on, don't jump on the back of a friend, somebody that'd like to be a friend unexpectedly, those kind of things. The inattentive ADHD, like my son has, usually is relatively late in diagnosis, often age 10 to 12, and that's because we don't really have a lot of expectations for attention and sustained attention up until about that time. By that point, the task would be to be sufficiently complex. So my son was 13 when I finally sat down with him and said, look, you've got an issue, and I won't treat you, but I've got friends who could. And he, for better or worse, chose not to. He really felt he wanted to do it on his own. He was doing well enough in school, despite the fact that he was having difficulties, that his wife, my wife and I, both of whom were brown-nosed, anything for an A kind of students, took a deep breath and said, you know, as long as your grades are adequate, which in his case was like B's and C's, we'll agree to this. We don't think it's a good idea. In retrospect, he sometimes wishes he'd done it because there were things that he didn't tell us about until much later that were much more difficult for him than we had realized. But at the time, he really sort of had this image of medicines turning him into a zombie, and he didn't want any of that. So he was actually in med school before he started taking stimulants. There's during the second year of med school, there's this huge test. In his particular medical school, they actually gave him 7 weeks off to study just for this exam, and he knew there was no way he could spend 7 weeks studying intensively, so he went to a psychiatrist and got a stimulant and used it during that period, used it sort of intermittently for a while. It wasn't until he got a girlfriend, who's fiance, who's now his wife, who finally said, you know, you do much better when you're taking this medicine than you do when you're not. So he now takes it on a regular basis, but didn't for many years. There's a broad choice between short and long-acting forms of both methylphenidate and amphetamine. In the United States, we typically tend to use the once-a-day long-acting forms. In Europe, and many other countries, short-acting versions are still actually, they're much cheaper, and therefore they tend to be used more. The only difference here is how often you have to take them. And we've got a slide that can talk about that. When you're dealing with how do we make these decisions, it really is important to figure out who the decision makers are. This can be particularly difficult if you've got a divorced family, for example, and one parent is convinced that the problem is the other parent's parenting style and refuses to give medications under any circumstances. I actually once, we do questionnaires as part of routine. I once had a teacher who was complaining bitterly about the child we were assessing, who at least had the good grace to write on the top, I don't believe in ADHD and will not support anything that would make this child get that diagnosis. And despite his behavior in class, put him with zeros, behavioral problems all the way down. But at least you let us know why. It really is nice. The children depend. There are some kids who are extraordinarily aware of their ADHD, and there are other kids who are incredibly unaware of it. I've had one of the things I try to get my trainees to do, particularly with combined type ADHD, is to bring the kid in first thing in the morning off medication. And the nice thing about stimulants is they work within about 20 minutes, so they can give it to them right at the beginning of a session, and they can actually see the difference that medication can make, as can you, as parents, between off medication and on medication. And it's fascinating to me, there are some kids who go from whirling dervishes who can't sit still at all to sitting quietly at the desk doing whatever you ask them to do, and will tell you nothing's changed. Everything is exactly, they are who they always are. Something we, again, don't understand. All right, one of the things that the MTA did that people now try to model that is really important is to get teachers involved. I know there are parents who don't want schools to know that their child has ADHD. The likelihood that the teacher doesn't, actually if you have a teacher who doesn't really recognize ADHD, that's probably not a good thing. And a lot of the symptoms that we're looking for, particularly if you're using stimulants, are going to be most affected during school. So having some sort of simple way of getting communication from the teacher about how are things going. You were asking earlier about how behaviors change. And with younger kids, it may be getting out of their seat inappropriately, yelling out things, poking their next door chairmate, those kind of things. With older kids, it may be fidgeting, not getting assignments turned in, etc. Teachers are often extraordinarily valuable about if my child were to change in a way that would help with his school, one or two things would those be? And keep it pretty simple. I'd say no more than 3 kinds of measures. And ask the teacher, you know, it's perfectly reasonable to ask the teacher to fill out a little questionnaire you can make yourself about, did he get his assignments turned in? Did he participate in class discussion? Whatever it is that the teacher finds problematic. And you can also ask, did he eat his lunch? Which the answer is almost always going to be no if he's on a stimulant. But keep it pretty simple, and keep them involved because they turn out to be a really good source of information. We don't have at this point a routine built-in way for physicians and teachers to talk to one another. It really often is the parents who provide that intermediary step. With the MTA, the teachers had to agree to participate in the study, so we actually were able to contact them once a month and get direct information out of them, which turned out to be very, very valuable, and one of the reasons that we sort of recommend that now. I have 2 boys. The older one does not have ADHD, never did, but did sort of go through periods of depression, and I could have kicked myself because sort of late November, early December, his schoolwork just plummeted, which we didn't know about until early January when grades came out, at which point he was getting sometimes D's and F's, by which time whatever it was that was going on with him had gone away and he was perfectly fine again, and he was the kind of kid who wouldn't talk about anything. So by the time we actually picked up this as a pattern, it went away and sort of stopped. It was like 4th, 5th, and 6th grade. 3rd, 4th, and 5th grade. So it would have been very helpful to have had feedback from the teachers on that his behavior's changed. Have you noticed that? Which the answer for, in his case, unfortunately, was no. Fortunately, he's doing great. So the other thing I strongly encourage parents to do is keep records. They don't have to be elaborate, but if you're going to have your kids on medications, do not assume that you're going to be able to get the doctor to remember what everything he's been on. So I recommend that you keep some sort of if you're computer literate, do an Excel spreadsheet. If you're not, do a calendar. It doesn't really matter, but pay attention to what medicines he's on, what doses he's on, what kind of benefits and side effects you're noticing. Height and weight, physicians normally will keep that, but it's certainly not bad to have yourself. And any other changes that you think might be relevant to treatment, like getting irritable late in the afternoon as the medicine wears off, things like that. And don't hesitate to talk to the doctor. I can't tell you how many families worry about just disappointing me. So they don't want to tell me that the medicine stopped working or that their kid's having weird side effects. I've seen pretty much every weird side effect there is possible, so I'm happy to hear about a new one. If the benefits are fading, we can address that. If there are new challenges that are coming up, like in 4th and 5th grade, when they begin to have more responsibilities, we may again have to change things, not necessarily medications, but what other kinds of support. One of the common things that happens, if for any of you who've had post-pubertal kids, 11, 12, and 13, parents' intelligence levels goes way, way down, according to the kids. Mark Twain actually commented that he couldn't believe how stupid his father was when he was a teenager, when Twain was a teenager, and how much smarter he got with the time Twain got into his 20s. He also recommended putting kids in boxes until they reach their 20s, but that's a different Mark Twain. But at any rate, one of the things that often happens is that parents end up with huge struggles around homework as kids get into 5th, 6th, and 7th grade, and sometimes later. And if you've got the resources to do it, getting somebody else to help them, so your job then becomes praising them for working with the tutor as opposed to trying to pretend that you understand new math, that can sometimes reduce friction within the household in an amazing way. Kids are much more likely to respond positively to an adult outside the family. And actually around here, a lot of colleges have tutoring programs, so you can end up with kind of a role model kind of thing where you've got a college student who's working with your child on whatever areas may be difficult. Yeah?
People on height and weight, how many % of the children show a problem there?
Almost everybody loses weight to some extent. The average is about 10%. In our society right now, among kids, that isn't necessarily the worst thing in the world. In some ways, it's not the weight loss that bothers parents so much as the fact that they're not eating well. Lunch really, for a lot of kids, just becomes the non-event. The 10% is as low as it gets, and on average, again, there are exceptions. There are some kids where the appetite suppression is really quite severe, enough so that it's an unacceptable side effect, and we have to try something else. Height, you end up losing about a ½ inch a year for the first 2 years, and then it sort of stabilizes, and that's compared to kids with ADHD who are not medicated. If you compare them to non-ADHD kids, it's more like a ¼ of an inch. So if your kid is destined to be a basketball player, stimulants could get in the way of that. Again, it really varies. And this is on one of these unfortunate situations where the poor get poorer. So short kids, in my experience, are more vulnerable to suppression of growth. It's not related to appetite. Those turn out to be very different mechanisms. So there are some kids who are growing just fine but lose weight, and their weight's going up just fine but they stop growing. Just different systems all involved. Fortunately, these are very easy things to monitor. These are not going to sneak up on you. It's not that your kid is suddenly going to be 2 inches shorter than he was the last time you measured him. And what we recommend is measuring about every 6 months. And there are kids where we have to stop the stimulant and go to other medicines because the growth suppression is quite severe. They just stop growing. It's completely reversible. It's also related to the total dose during the year. So depending on the kid, if you can get away with not giving medicines on weekends and on school holidays and that kind of stuff and on summers, that can actually help diminish that impact. So studies have now shown that you may have to increase puberty is a phenomenon that you have to get through in so many different ways. But with puberty, there's a huge change in the way the liver handles medications. There's also changes in brain structure and the systems that these medicines are working on. And there are other changes in the body that can really cause a very different response to medicines than before puberty. So you may or may not have to sort of reassess medication dosages in and around puberty. Otherwise, in general, it's weight related. They don't develop tolerance over time as far as we can tell, and there have been kids who have been on medicines for 15 years steadily and still do very well with them. Stimulants seem to be least likely to develop tolerance, probably because their metabolism is less complicated. Than some of the non-stimulants, it becomes more dicey as to whether they're going to have the same response before and after puberty. I break kids down broadly into sort of 5 and under, 6 to puberty, and then puberty and above. As much as possible, I avoid using medicines below age 5 for lots of different reasons, partly because they just don't work very well at that age, and partly because there are other ways we can deal with that. The best studied age group is by far 6 to 10. For a long time, that was the only group we had data on. There's still only one study of kids below age 5 with ADHD, and that's with methylphenidate. And there are now more and more studies of adolescents and adults. And the dosing changes because of size, but the response really doesn't seem to wear off over time. If it does wear off, usually that's because there's something else going on that we need to sort of figure out and diagnose. Yeah?
Yeah, I have a question. One thing is so the first question is, does the starting use age matter with the age?
That's a great question. I mean, sort of the answer is an obvious yes. I mean, obviously, if you don't start till after they're fully grown, then there's not going to be an effect on height. The one study that we've got available with kids under age 5 suggested there was more of an effect on height than we saw later on, and also that the response. No, actually, we're talking a year's exposure. That there's more of an effect in kids 3 and 4 years of age.
But then they use it from 2 years, from 6 to 8, but after 8 you stop. The height eventually will be impacted? Because you also use the word completely reversible.
Well, it's completely reversible in the sense when you stop using stimulants, that effect goes away.
But will the kids catch up?
It's a complicated answer. Compared to other ADHD kids, the answer is no. Compared to non-ADHD kids, it's a qualified yes, because it turns out that unmedicated kids with ADHD, on average, are taller than their non-ADHD peers. So they look like they catch up, but the data suggests that they wouldn't catch up to where they would have been had they never been on medication. But that 1 inch really is as bad as it gets. We looked at kids in the MTA when they were 18, and again, compared to their kids who'd never been on medication that whole period of time who had ADHD, they were about 1 inch shorter.
So this height difference is due to they don't eat much, or is
No,
it something
it's
from other-
unrelated to appetite completely. We believe it's related to growth hormone. One of the things that dopamine does is to drip onto the hypothalamus in an inhibitory way. So when you're using stimulants, that increases that, and we think it affects growth hormone. The data aren't as robust as we'd like, but we think that really is the effect on height. Growth hormone is very difficult to measure because it's not a constant thing. It's a pulsatile. It's a mess. Yeah.
You know, so surprisingly with, my daughter is 17, what we observe with her is that the medicine, whenever she changes, it works for about 6 weeks. Then it just settles and the benefits just diminish very quickly. So I don't know what.
Yeah,
And it's never an eating problem with her.
Right.
It doesn't have that effect that she loses appetite.
Right. Yeah, interestingly enough, one of the unexpected findings out of the MTA when they looked at 18-year-olds was that kids who had been on medication for essentially 10 years actually had obesity problems
That's true with her.
at that age. We think that's because they're so used to not having to suppress their to control their appetite because the medicine did that, and that effect seems to wear off eventually. And so compared to kids who've never been on ADHD medications, by the time you're a late teen, you have an increased risk of being obese. One more, and then we're going to actually move on. Yeah.
Post-pediatric learners, with the use of drinking caffeine, does that have any interaction with their?
It's a little. Caffeine is a stimulant, and it has stimulant properties. My son actually, for a while, because he was in a I don't want to take meds mode, bought caffeine tablets and he'd use coffee for a while, but decided that was far too non-scientific for being a physician. So he bought caffeine tablets and would dissolve one under his tongue every morning. Lasted about 2 hours. It's a relatively mild stimulant. I mean, what I wouldn't recommend is giving it in the form of Coca-Cola or Pepsi or whatever your favorite brand of caffeine is, or coffee for that matter. So if you're going to do it, I'd recommend trying caffeine pills. But it's a pretty, there's no evidence that it's better than what we've got. It's just shorter acting, basically.
Does it interact? Because I have students.
Not really. I mean, it may increase. I mean, it depends on how people respond to stimulants. I mean, to caffeine, but they'd have to take a. I mean, if they're taking, what is it, Jolt? Is that or Bolt or whatever that hyper-caffeinated and other things in it drug is. That I would recommend, but small doses of caffeine are probably not going to have much of an effect. But if they do, then that's data. I mean, every kid can vary. All right, and then that's very briefly, don't make changes at key transitions. This is not the kind of thing where you want to make a medication change a week before the kid's taking his SAT, for example, or ACT or whatever test they might be taking, or even just before finals week, those kind of things. Think about what's coming up, and particularly, it is good to make changes during school, but you want to make them during a time when there's not a lot at stake. And I usually get teachers involved, so what I'll often do is if we're changing medications is to encourage the family to say, we're going to be making some changes, we'd rather not tell you exactly what they are, but we'd like you to sort of pay attention if you notice anything good or bad about behavior, and tell your child, good luck with that, not to let the teacher know which days he's taking what medicine. But that can be a very useful sort of blinded source of wow, he's did a lot better in this area and not so good in this other area. And we already talked about puberty is a time when sometimes significant changes occur and we just have to deal with it. As I mentioned before, we really have an enormous amount of research, particularly on so-called latency age kids, 6 to prepubertal. And there are medicines that definitely improve the major symptoms that we associate with ADHD: inattention, distractibility, impulsivity, and hyperactivity. As I mentioned earlier, they've got no direct benefit for executive functioning, learning disabilities, language problems, or social skills. One of the things that I often have parents come to me with an 8 and 9-year-old is I want my kids to have more friends. I don't have a pill for that. Being less impulsive may make it easier for the child to develop friends, but that's what social skills groups can do and some other kinds of non-medication interventions. We do not have a friendship pill yet. Maybe someday, but we don't. As I mentioned, right now, all of the evidence we have is that whatever changes are occurring are transient, and they go away when you stop the medication. So there's no permanent changes on brain function. Largely, we think that's a good idea, although obviously if we could really, quote, cure this, that would be wonderful, but we don't really have that possibility. So far, research has not shown any suggestion that the treatments that we currently have, not just medications, but others, really change the underlying course of ADHD, which is, remember, gradually getting better, but not necessarily completely going away. So medication options, we're not going to have time to do nearly the detail I suspect you'd like, but they sort of break down into two. So there are the stimulants versus the non-stimulants. Within the stimulants, there's methylphenidate and amphetamine. All of you should have a copy of this on your seat. If you'd like extras, we've got some up here. You're welcome to have more. This is provided by a colleague of mine on the East Coast, completely. He does it all on his own. He takes the pictures himself. They are close to life size. Getting them on this sheet of paper, I had to reduce them just a little bit. And you can get free updates. There's on the bottom on the amphetamine side, there's a website where you can go to and either just download this for free, or if you want a laminated version, you can get it for a reasonable price. It breaks down into stimulants and non-stimulants. Within each, it breaks down into short-acting versus long-acting. Then there are the non-stimulants, which also break down into two categories. There are the so-called alpha agonists, which are these two, and then there's atomoxetine, which sort of stands by itself. These are the FDA-approved medications, and the only thing he lists here are the ones that the FDA has approved for ADHD. Most of these are approved down to about age 6. A couple of them are approved into adulthood. Amphetamines tend to be more likely to be approved for adolescents and adults because they came out at a time when that was a potential market and the companies were interested in it, so they actually got studied for it. Stimulants Advantages, they've been around a long time. We know their warts as well as their beauty marks. They're highly effective, as I talked about before. They act very quickly. Once you get to the right dose, within 20 minutes you should see the benefits from the stimulant. It's going to last, depending on what version you use, anywhere from a couple of hours if it's a short acting, up to as long as 14 hours if it's one of the longer actings that's designed to last that long. And as we talked, they work at least 65%, somewhere between 65 and 85% of the time, depending how you want to count. They can also be used selectively, which some parents really like, particularly if the main problem, like with inattention, is at school and not so much during the weekend. I've had parents who either skip weekends altogether or give a lower dose, or just give it if they're going to a special activity where, again, being able to pay attention is really important, and they don't use it other times. They don't use it during the summer, et cetera. And there are a variety of forms available, which are nicely documented here, which mostly different in how long they last. The disadvantages are they only cover part of the day. So if your kid is having huge problems in the morning or in the evening, stimulants are not likely to be exceptionally useful for you. There is one new medicine that just came out in January, I think. I didn't get a chance to call the pharmacy to see if it's really out, which is a night before stimulant. You take it the night before. It's called Journey PM. It's actually not on that sheet, but it is in my list. And it's that new. And it's designed to be quiescent for about 10 hours, I think, is my recollection. And then it's designed to be long-acting, so it lasts about 12 hours. And the idea is that the kid wakes up with with it in his or her system, so you can make it through the morning if you have a particularly chaotic morning. I have not used it yet, so I don't know. I mean, I have some concerns about it because breakfast, for example, might be affected, and breakfast is one of the meals we really rely on kids getting calories in. But there are some kids where I could imagine it would be useful. Late at night, stimulants are not going to be on board. So if you have a kid who does most of his or her studying at 10 or 11 or 12 at night, stimulants are probably not going to be very helpful with that. There are some kids where stimulants have little effect on sleep, and sometimes they can get away with taking a stimulant late at night. One of the first 18-year-olds I treated with ADHD, he had a perfect high school record, which turned out to be because his parents had created an environment where he didn't have any choice. When he went to college, he went from all A's to F's, D's and F's, and at that point we only had short-acting methylphenidate. He would start taking methylphenidate at 4 in the afternoon and take it about every 2 hours, because that's about how long it lasted, until 10, and that would get him through all of his homework. And then he usually got to bed about 2 in the morning. He didn't take morning classes, refused to take stimulants during class because he thought classes were a waste of time. And he went from, none of this was my recommendation, it's what he chose to do, but he went from D's and F's to all A's. Got through college without any problem, and now holds down a very responsible job, and I'm sure is taking it differently because unless he got a job that there's night hours. At any rate, stimulants are not our go-to medicine when the big problems are either early in the morning or late at night. Often non-stimulants can be better for that, and we'll talk about it. Prescribing is restricted, so I can't tell you. In fact, over the weekend, I stupidly forgot. I had a parent who had gone somewhere and forgotten their pills and wanted some stimulants to hold them over the weekend. So I called the pharmacy, and they, of course, reminded me, you can't order stimulants over the phone, Dr. Elliott. And we were able to deal with it electronically these days. But you can't do refills. You can't call it in. You basically, there are significant restrictions. They're actually much worse right now because stimulants fall in the same broad class as opioids. So this whole opioid crisis, everything they've applied to opioids also applies to stimulants. So the amount of effort involved in prescribing stimulants has gone up considerably. The side effects are well known, and they're not universal, but they're very common. Decreased weight, we've already talked about them. Possible effect on height. Insomnia, we haven't talked about. Most kids end up with somewhere between 15 to 30 minute delay in sleep. Again, sometimes it's less, and 15% of the population, actually I had an adult who took 5 milligrams of methylphenidate as a sleeping pill every night and claimed she couldn't sleep without it. But most kids end up with some level of insomnia. Usually it's not horrible, but sometimes it is, and we have to switch. Again, this is one of those side effects that if you switch over to the other class, sometimes the side effect goes away. If you are susceptible to having motor tics, Tourette disorder is probably the most well-known, but some, facial tics or vocal tics, it will uncover those tics. Again, that's a reversible phenomenon. There's now good evidence that it doesn't permanently alter the course of the tic disorder, but many kids who have Tourette disorder start out looking like they have ADHD, so they end up on stimulants and then their tics appear about that same time anyway, and for a while it was believed that stimulants cause tics. There's strong evidence now that they don't, and that it's safe to use stimulants even if you've got Tourette disorder. You just have to also treat the Tourette disorder. And it can flatten personality. This probably caught me most by surprise when I started in the field. I expected like antipsychotics, like Thorazine back in the day, to be medicines where parents would talk about the zombie effect. Stimulants are really the only med class where I've ever had parents say, it's great, he's better, but he feels like a zombie to me. What it means is personality is kind of flattened out. Again, it's not a universal effect. It is dose dependent, but it is a side effect that if it happens, don't hesitate to let people know, because again, that may be worth trying a different type of drug. I'm not going to go through all of these. The next few slides basically just list what's out there, what's available. There's the new one I mentioned, Journey PM, and it's supposed to, again, you take it the night before and then it's supposed to work most of the day. The Daytrana patch is kind of interesting. You may see that over here. It's a little hard to see with this, but the bright thing is the package, and then you'll see a sort of a shadowy thing, which is actually the size of the patch. I don't usually recommend these except for adolescents. The one nice thing about the patch is it's the only form that we've got where you can determine how long a day you want the medicine to work. It takes about an hour or two for it to kick in when you put it on, and it lasts about 2 hours after you take it off. So if it's adolescent or adult, you know you're having a long day or a short day, you can adjust it. A lot of kids don't tolerate it because it can produce a localized skin reaction. You have to take it off every day, and it takes off a thin layer of skin each time because that's the way you keep people from using it inappropriately. So it's not so great. Quillavant is a liquid that I haven't used very much, but is a long-acting version. If you've got kids who are really, really sensitive to different doses, it's one way of being able to adjust the dose pretty precisely. And then amphetamines have been growing exponentially. For whatever reason, the FDA seems to be having a great time approving brand names for old versions of amphetamine. Most of these are, again, extended release. There's a liquid version of amphetamine as well, which is Adzenys, I think, yeah, Procentra as well. Procentra is, I believe, yeah, the immediate release, short-acting version.
Adderall and Ritalin come in generic form.
Generic, yeah. Most of these, well, the newer ones, no, but most of the most used ones are now available in generic form. So the most used on the amphetamine side is Adderall XR and Vyvanse, and on the methylphenidate side is Concerta and Focalin. And those are all available generically. Although Focalin, weirdly enough, the brand name is cheaper than the generic. I have no idea why. And then Vyvanse is unique in that it's a prodrug. The company was hoping to get it out of the scheduled mess that we talked about earlier about how difficult it was to prescribe. It's amphetamine linked to an amino acid called lysine, and in that form it's inactive. You take it, it gets taken up into the red blood cells as a ubiquitous enzyme that cleaves the molecule, and voila, you have amphetamine. So it's slower acting. It can take up to a couple of hours to really kick in. It's among the longer acting. It works for about 12 to 14 hours and has a very different kind of curve to it because you're not getting an immediate release and then decrease. Non-stimulants have some advantages. They provide 24-hour coverage, which the stimulants do not when they work. They can be as effective as stimulants when they work, and they tend to have side effects that are quite different from the stimulants. They tend to be sedating. They have less of an effect on appetite. They don't affect growth as far as we can tell. And they're also easier to prescribe because they're not Schedule II drugs, so you can do refills and those kind of things. The disadvantages, they don't work immediately. They can take weeks to work. They only work for about 40 to 45% of, I said, yeah, 40 to 45% of kids rather than 65% of kids like the stimulants. They sometimes have unacceptable side effects. The most common are daytime tiredness. 2 of them are high blood pressure medicines, so in theory, I've really only had one kid where that was a problem, but in theory, they could lower blood pressure, and that could become a problem. So you do have to monitor that. And they also, and this is a sort of a mixed blessing, they don't really provide a sense of a cognitive boost. So one of the things that most stimulants do is make kids feel like they're performing better. Interestingly enough, that doesn't actually jibe with how they're performing. There's not much of a correlation. But if you ask kids, how did you do on a test? If they're taking a stimulant, they are likely to overestimate how well they did. Systematically. That doesn't happen with non-stimulants. Atomoxetine was the first FDA endorsed one. It's an antidepressant, works on the norepinephrine system. Exactly how it works within the brain, we don't really know, but it has been shown to be effective. Again, in about 40-45% of the cases. There's a delay in action. Most common side effect is nausea, sometimes vomiting, which isn't a whole lot of fun, and daytime sedation. There's also a black box warning about it because all antidepressants have the potential for increasing suicidal ideation, and so there's theoretical risk of it doing that. One of the nice things is both it and guanfacine, which are the two that we use most commonly, are compatible with stimulants. So sometimes we end up using the two of them together because the side effects sort of cancel one another out and the benefits are at least additive. So particularly with kids where hyperactivity and impulsivity are real issues, sometimes the guanfacine or the atomoxetine can be really helpful in reducing that. Then you can end up using lower doses of stimulants to help with attention, which is more responsive to stimulants. It too has a delay in action, about a similar kind of response rate overall, and sedation is by far the most common side effect. And then clonidine rather, which is actually, ironically enough, the most recently FDA approved, but actually has been around the longest of the non-stimulants, is for a while we used to use a patch, and it's still available in that, but we essentially never use it. Capva's only been out for about 3 years, and it's very similar to guanfacine, except that it's more likely to be sedating, and also if you miss a dose, there's a risk of what's called rebound hypertension, so your blood pressure may get up into dangerous levels. So I frankly don't use it very often, but it is approved for use. It comes in a twice daily version in terms of long-acting. There are some medicines that we use commonly, particularly in adolescents, that aren't FDA endorsed but have been used for a long time. It's for a variety of reasons. The companies have not bothered to try to get FDA approval. One that I particularly like with adolescents is called Bupropion. It's a unique antidepressant in that it works on the dopamine system. You can think of it as a weak stimulant, so it's not going to help with kids who are really severely hyperactive and impulsive. But if you've got an adolescent where inattention is the biggest issue, it can be really, really helpful. Provides enough benefit for that, and it provides 24-hour coverage. So the kids who are working late at night, this may be a reasonable option. And then the other ones are these are all antidepressants of one form or another, and then this one is again a unique type of stimulant that almost got approved by the FDA for ADHD, and for a variety of reasons ended up not quite, but has been used at times, and again provides 24-hour coverage when it works. All right, so we're going to stop here. Essentially, right now, the pharmaceutical companies seem to be mostly focused on coming up with new ways of getting FDA to approve old drugs. There really is remarkably little in the pipeline that really suggests that there's going to be a major difference in what we've got. Omega fatty acids are being used. There's some evidence that they may be somewhat helpful, and there's a focus on a couple of brain systems that actually probably have more to do with executive functioning. So far the data from those are really not very promising. So I'm going to quit there. You can read. There are some common patterns that you see that require certain kinds of responses. If you get to a kid who's got any of the kinds of things that we're talking about, probably it's time to be working with a child psychiatrist or a behavioral developmental pediatrician. Let me stop there. I will be happy to be around for some questions. Yes, sir.
Can you comment on the use of both stimulant and non-stimulant drugs at the same time?
Yeah, it's very common. We have, I guess, the mixed fortune. There's a company that I frankly don't like very well that produces both a stimulant and a non-stimulant. That's the first company that's been motivated to show the safety and efficacy of using them together. And they are in the process of studying that and trying to get FDA approval for that particular combination. But physicians have been using the combination for a long, long time, certainly all of my professional life. The advantages of what we talked about is that the benefits are probably at least additive, and the side effects tend to cancel one another, particularly related to appetite and sleep kind of problems. So something like guanfacine plus one of the stimulants is a very common and, as far as we can tell, quite safe practice. And often you can get away with lower doses of the stimulants, which means that the effects on appetite and growth get diminished as well.
You had mentioned at the beginning that there's some types of school structures that can be shown
No, as effective.
Yeah, can you give me a window into just point me in the direction? of
Yeah,
where you
look up
should
Jim
go?
Swanson.
Pardon me?
Jim Swanson,
Okay.
SWAN, like the frozen dinners. He's not related to that guy, but yeah, he's got a school down in Irvine that he's run for 35 years where it runs like clockwork. Another guy who does, actually has a summer boot camp that works, and has also shown to be as effective as medication, is a guy named Bill Pelham, Pelham. Both of those, the trouble is they're very behaviorally oriented. You have to have experts who really know how to do it. And
Nothing around here.
no, we don't have any schools around here that follow that model.
There's no rule of thumb like, Montessori schools or very strict.
Well, there are several rules of thumb. Unstructured settings are bad for ADHD kids. So any school that basically says kids can do whatever they'd like to do because they'll learn naturally are likely to be ones that eventually kick these kids out because what they learn naturally to do are things that the schools don't usually tolerate. So well-structured schools that are positive in terms of praising kids for doing things well. I'd recommend, if you haven't done any reading, there's a whole bunch of suggested readings in the back, both websites and also books. A guy named Russell Barkley has done some wonderful books for parents where he can describe the kinds of things that one needs for a child in a classroom to succeed. It's really not magic. I mean, this has been looked at very carefully. The difficulty is that if you've got one teacher and 30 to 40 kids, and you've got, an expectation is you'll have at least 2 kids with ADHD in a class that size. What the teachers will tell you is that they would have to spend all of their time focused on those 2 kids if they were going to provide them with the kind of education they needed. So.
Is it accurate that ADD and ADHD used to be mutually exclusive enough to where they were treated differently?
No, actually, they were. The diagnostic schema were different, but the underlying principles really are identical, which is why they ended up combining them. So now there is no ADD. Everything is ADHD, and you have inattentive subtype, combined subtype, and impulsive hyperactive subtype. But back in the Stone Ages, back in the late 70s and 80s, they did have. Actually, they had the original that I came across, which was in the early 80s, they had ADDH and then ADD, and you never knew whether they accidentally left the H off or not. But so we talk about ADD with hyperactivity or without hyperactivity. The main difference is how many. Essentially, there are 2 buckets that we look at. One is inattention and distractibility. There are 9 criteria. You have to meet at least 6 of those to meet that category. And then there's impulsivity and hyperactivity, which we've desperately tried to separate but don't seem to be separable. They basically sort of come together. Some kids are more impulsive rather than hyperactive. Some kids are more hyperactive than impulsive, but usually those 2 things sort of cluster together. Again, there are 9 criteria. You have to meet at least 6. It's a bit arbitrary, so there are some kids who are mainly inattentive, but they have 4 or 5 of the hyperactive impulsive criteria, which can certainly affect their behavior, but doesn't formally qualify them for a diagnosis of combined type.
But the expectation is all these medications are optimum for
Yeah, right, right. It hasn't been as well studied with ADHD inattentive type, which is, it's better studied now than it was when my kid was young, but that was part of why I chose not to push medication, because we just didn't really have a lot of evidence at that point how useful it is. It turns out actually it's a very responsive subgroup because inattention turns out to be much more responsive to stimulants than hyperactivity and impulsivity. So usually relatively low doses of stimulants can be very effective for the inattentive subtype. Yes, ma'am.
Do you, from your experience, do you see if the kid has both ADHD and dyslexia, treating one, helping with one will help with the other?
Yes, absolutely. Mostly, not directly, but indirectly. It's what I was talking about with the deaf child. if you've ever sat through a course on how to start reading if you're dyslexic, it's lots of repetition, lots of things that you have to do that you find really, really boring, and being able to pay attention and do those tasks is going to help you hopefully be more motivated. So yes, I absolutely would recommend it under those circumstances, not because it's going to help with the dyslexia per se, but because it makes the kid more teachable. If you've got executive functioning problems and ADHD, how do you know what's what? So if executive functioning is definitely not going to be helped if the kid doesn't get the information of what he or she's supposed to be doing to begin with, which is where ADHD comes in. So if you improve attention, the likelihood that the child will be able to at least have the information of what the assignment is increases. And probably the likelihood of the child turning the homework in once he's done it. There's nothing more maddening, and I'm sure many people here have experienced it, I certainly have, of working late into the night doing a project, and then the kid doesn't bother turning it in, and then he loses 20 points because he finally remembers. I'm sure that's never happened to anybody here, but although the latter is frankly probably more responsive to sort of a behavioral program where they get a reward for making sure that things that they take to school get turned in.
Kind of a golden thing you said, like as a teacher, what kind of things they should keep track of to see whether the medication is effective, if it cannot be, necessarily things that are.
Well, like turning in homework might be one of them. Paying attention in class, participating in class discussion might be one. Again, it's going to depend on whether the kid is mostly inattentive or hyperactive. If they're more hyperactive, then things like not getting up out of his seat, not jumping on other people, those kind of things, not jabbing. Just paying attention to the teacher is one.
It would be something that the teacher would really, without, like with homework, you can set a number. It's 3
Sure.
or 5, but with attention, I'm a little concerned whether it would be.
Yeah, most teachers know who's paying attention and who's not, even in a large class. Yeah. The two of you together.
Yeah, what help I said, so for the combination of drugs or taking either one, the non-stimulant or stimulant, is there preference taking the combination compared to individual drugs?
Well, so the question is there a preference between taking a combination of like a non-stimulant plus a stimulant or just one or the other? It partly depends on where the problem is and how, what you're trying to treat. In general, we prefer to use fewer medicines rather than more medicines. So there's that pressure. On the other hand, the other principle is using as low a dose as we can get away with. So they're a little bit competing. And this really is one of those things where what I do if I'm start working with somebody is sit down and go through the whole day and find out where the problem areas are. And help decide around the medications based on that. If there's lots of problems in the evenings, we know stimulants are not going to help with that. So we're going to end up probably recommending a non-stimulant for that part. If the school is complaining, yes, the kid's quieter and less disruptive, but still not paying attention, then we might think about adding a stimulant at least on school days.
For melatonin, if you want to try and help your child sleep at night, would you recommend that as a non-stimulant?
It can help, and again, doses vary anywhere from milligram to, I've had kids go up to as high as 10 milligrams. Probably anything over 5 is kind of a waste of time. Again, you want to buy a quality brand. The FDA did a study a few years ago where they found a fair number of over-the-counter melatonin actually was adulterated with anticholinergics, which is what you get with Sominex, for example. So you're basically getting to sleep not because of the melatonin, but because of something that sedates you. Melatonin itself, I think, is quite safe, and it's been used for and can be very effective for some kids, and it really depends on the child. But again, get a good brand. Don't cheap out. Yeah, you, ma'am.
Okay, a couple questions. One is, does ADHD get recognized as a learning disability, so to say, to get accommodations?
No. But ADHD by itself does not. It is covered under so-called Americans with Disabilities Act, so you probably have heard of 504 accommodations. Those are sort of low to no cost things like where the kid's seated, being able to have more time for test taking, those kind of accommodations. but by itself, ADHD will not qualify you for an individualized education plan, doesn't count as a learning disability.
The second part to that is use of TMS. Do you have any data that the transcranial magnetic stimulation has?
For ADHD, none at all. Yeah, as far as I know, it's not even been studied. It hasn't been studied a lot, and it hasn't been studied at all in kids. It's only recently begun to be studied in adolescents. People familiar with this? This is a very interesting technique that's been used now for a variety of things, where you can focus using a supermagnet. You can actually focus a magnetic stimulation into deeper parts of the brain and sort of create a mini seizure, essentially. And it's been shown to be helpful in depression, probably in anxiety. Those are the two areas that it's been most commonly studied. It is actually being looked at autism. I'm not aware of studies of ADHD, and there's no particular reason. It can't go deep enough to affect the areas that we think ADHD and buzzing the frontal cortex is probably not going to have much of a positive benefit. So.
What's your go-to medication if a kid comes in with first-time diagnosis?
Doesn't really matter. I have a go-to, but it doesn't really matter because each doc. I mean, when something works 65% of the time, you feel like a god. So whatever you get used to using, what I usually recommend to my residents is pick one methylphenidate and one amphetamine medicine that you really feel very, very comfortable with, and then learn what the dose equivalencies are for the other ones. But there's no evidence that one works better than the other. I happen to use methylphenidate more. I was involved in a Concerta was actually developed here in Palo Alto by a company named called Alza, and I was on their advisory team, and it was the first one out, and I loved it. I frankly don't use it quite as much these days as Focalin, but I do stick with methylphenidate. It's strictly bias. There are colleagues who start with either Adderall XR or Vyvanse, and I have no argument with them whatsoever.
What is your end goal to increase the dosage?
So what you're looking for, this is unfortunately kind of like toast. What you're looking for is you keep raising the dose until either it's dark, which means in this case you've got side effects that you don't like, or it's exactly the shade you like. You've got nothing left to improve. Everything's going wonderfully. And unfortunately, more often than not, it's you raise it until you get side effects and then you back off a bit. The science of that is more art than anything. Yes, sir?
So, about side effects, so long-term side effects and stimulant-based drugs, as far as aggression, things of that sort, can you expand on that?
Well, I'm not sure what you're asking. Does use of stimulants increase aggressive behavior? Is that what you're asking?
Correct. I mean, there's short-term effects, right?
Right.
But the long-term effects of taking the stimulants?
We are not, so far, other than height and weight, and including blood pressure. It does actually raise blood pressure, but it doesn't do so in an incremental way. Every time you take it, your blood pressure goes up a little bit, but it doesn't seem to have any long-term effects. There's no suggestion that kids, good or bad, there's a little bit of research, which is really pretty shaky, to suggest that use of stimulants in adolescence decreases the likelihood of experimentation with things that you'd like them not to do, like driving really fast, having unprotected sex, using other drugs, substances of abuse, that kind of stuff, starting smoking, using alcohol, etc. There's a beautiful research done by Bill Pelham that looked at college-age kids. These were kids that he'd known since they were 8, and he followed them into college and compared them to non-ADHD kids. And rather to his surprise, he found that the likelihood of experimentation with things that parents believe their children don't do in college, like all of the things I just mentioned, was indistinguishable between kids with ADHD versus kids without ADHD, and pretty high. It's about 40% of kids start having sex, start at least trying cigarettes and marijuana and other things. So there's no difference in terms of the likelihood that on or off medication with ADHD that they're going to be prone to doing those kinds of experimental things. What's different is that if they do try those things and they finally graduate from college, if you don't have ADHD, most people give up those behaviors and they go on about their life. Kids with ADHD have much more difficulty giving up habits that they acquired during college. So if they start drinking, they're more likely to continue to drink, et cetera.
So for the height and weight, it impacts the appetite, it will impact the weight for sure. So if it's the weight keeps growing, and then like the height will also be impacted, or what's the relationship between the weight and
They're completely independent of one another, but they both can be affected. And both are very easy to monitor. And there are growth curves. So what we're looking for is if the child begins to fall off his growth curve. I had a patient actually just came back to me. They've been in New York for about the last 4 or 5 years. I started treating him when he was 6. Parents were terrified he wasn't going to grow. He's now 6'2", and I think he's 17 now or 18. They no longer are worried that he's going to be short. But there are other kids where it actually is a real issue. I had a mother last year who the medicines were very effective. I wasn't prescribing the medication. I was involved in other ways. The medicine was very effective, but he had stopped growing for the previous 2 years, and his doctor appropriately wanted him off of the stimulant, and the mother was terrified to do that because of the difference in his academic performance. And he was on other things that just didn't work as well as the stimulant did. Basically, they ended up compromising, and he sort of stayed on it till the end of the year, and then went off. And then we recommended trying some other things that wouldn't affect his height. But he actually stopped growing for 2 years at a time when he should have been growing. So occasionally you'll see that, and that calls for that's a red warning light that you got to do something. Yes, ma'am.
Why is the short-acting methylphenidate now out of favor?
Because methylphenidate lasts about 2.5 hours. So which 2.5 hours of the day would you like to
Can you take it like over?
Sure you can. So then you have to arrange with the school to have the child take it every 2.5 hours. A lot of schools don't do that well. That's all we had when we were doing the MTA, and one of the horror stories we had was that a teacher who was involved in the study thought the best way to make sure the kid got the medicine was to just put it in front of her desk, and he had to come up in front of the rest of the class and take the pill. And we didn't hear about it until some other kids say, that looks interesting, and took the pill. And then the teacher completely freaked out and was convinced that she'd poisoned the kid, which was not the case. But it involves the school in a much more intimate way that can be really difficult. They do things like expect kids to stop in the middle of recess and remember to go to the school nurse to take their pill, those kind of things. So the reason it's popular is because you have a lot more control over how long it acts, and you don't have to worry about anybody else. There's no intermediaries. And I think, particularly now that many of those are generically available, I think it makes a lot more sense. Last question.
One of my sons always giving me the troubles, and I don't understand why. Until recently, one of my friends, she has a kid with ADHD, and she told me all about this. So I just started to know ADHD. But he's teens already.
It happens.
Where should I start?
I'd say with an assessment, we have a clinic here that we actually assessed a 17-year-old recently. You can call. There's a number at the end of the sheet that you can call. Yeah. Or you can. There are other places around here. If you look up Adhd Evaluations, there are people who do that.
Can I ask you a quick question?
Yeah, you bet.
This executive function reduction is always part of ADHD, or is it
No,
a separate thing?
it's really. It's more common in ADHD, but it's a separate thing.
It doesn't have to have it.
Right.
Sorry, I had a connected question. Is there strategies or resources to help with that?
Yeah, there are so-called executive functioning coaches. It's actually a very thriving industry right now, and that's what they do for a living is to sort of identify the specific kinds of problems. And there are bunches of apps these days that are available that help sort of compensate. It's really like having a crippled leg. You're going to do external kinds of things that kind of help compensate for the problem.